Welcome to OET Answers.
Occupational English Test. OET Answers Practice Test, Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear an ophthalmologist talking to a patient called Joey Root. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good afternoon, Miss Root. You've been referred to me because your doctor suspects you might have a condition called optic neuritis, which affects the optic nerve and can lead to vision problems. I'd like to get a clearer idea of what's been happening. Could you start by telling me about your symptoms?
Sure. It all started about 2 weeks ago. I noticed my vision in my right eye was becoming blurry, almost like a cloud or fog over my eye. At first, I thought it was just due to being tired, but it kept getting worse, especially when I'd wake up in the morning.
I see. Was it just the blurriness, or did you notice any other changes?
Well, after the blurriness started, I began having trouble with colours. They looked faded or washed out, especially reds. I'm also feeling some pain behind my eye, mostly when I move it. It's not unbearable, but it's uncomfortable, and the pain seems to get worse when I look up or to the sides.
That's helpful to know. It sounds like we're dealing with some classic symptoms of optic neuritis, especially the blurred vision, pain with eye movement, and color desaturation. Have you had any other issues, such as double vision or flashes of light?
No, I haven't noticed any double vision or flashes. It's mainly just the blurriness and the pain. I'm really worried, though, because my vision hasn't improved at all. And I'm starting to feel anxious about what might happen next.
I understand your concern, especially with something as crucial as vision. We'll work through it together. Have you noticed if anything makes the symptoms worse, like heat or physical activity?
Yes, actually. I forgot to mention, I've noticed that when I get overheated, like after a shower or exercise, the vision in my right eye gets even blurrier. It's scary because it feels like I'm losing sight for a bit.
That's what we call Uthoff's phenomenon, where symptoms of optic neuritis can worsen temporarily with an increase in body temperature. It's not unusual, but it's definitely something to monitor. Have you had any previous episodes of vision problems or anything similar before?
No. This is the first time I've had anything like this. I've always had pretty good eyesight, and nothing like this has ever happened. That's why it's so unsettling.
I understand. Optic neuritis can sometimes appear out of the blue, but it's also important to know that in some cases, it's linked to other conditions, particularly multiple sclerosis, MS, which affects the central nervous system. Have you experienced any other neurological symptoms, such as numbness, tingling, or problems with coordination?
Well, now that you mention it, I have had some occasional tingling in my hands over the last few months, but I didn't think much of it. Could that be related?
It's possible, yes. Tingling and numbness are symptoms that we sometimes see with MS, but it's important not to jump to conclusions. Not everyone with optic neuritis has MS, and there are other conditions that can cause these symptoms as well. We'll need to run a few tests to get a clearer picture.
What kind of tests would that involve?
The first step will be an ophthalmic examination, where I'll look at the optic nerve using special equipment to see if it's swollen or inflamed. Then, we may order an MRI scan to check for any signs of inflammation in the brain and spinal cord, which can help us determine whether there's a link to Ms. Another test we might use is called a visual evoked potential test, which measures how quickly your brain responds to visual stimuli. This can give us more information about how well your optic nerve is functioning.
That sounds like a lot, but I'm willing to do whatever it takes to get to the bottom of this. I just want to understand what's happening to me.
I completely understand, and it's important that we get as much information as possible so we can make an accurate diagnosis. In many cases, optic neuritis improves on its own within a few weeks, but sometimes we need to intervene with treatments like corticosteroids to reduce the inflammation more quickly. Have you been on any medications recently?
No, not really. Just some over-the-counter painkillers for the eye pain, but nothing major.
That's fine. If we confirm optic neuritis and decide on treatment, corticosteroids can help with recovery, but they don't affect long-term outcomes, so we'll also be focusing on any underlying causes. How are you managing your daily activities? Has the vision problem affected your work or other parts of your life?
Yes, it's been really tough. I'm an architect, so I rely heavily on my vision for drawing and designing. Lately, I've had to take time off work because I can't see well enough to do my job, and it's been really frustrating. I feel like I'm stuck in limbo.
Extract 2, questions 13 to 24. You hear a neurologist talking to a patient called Clara. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Clara. I'm Dr. Malik, and I'm here to talk about the issue you've been dealing with, head lice. How are you feeling today?
Oh, I'm fine, but honestly, I feel a bit embarrassed. I can't believe I'm here because of lice. I thought this was something only kids got.
It's actually quite common for adults to get head lice, especially if you've been around children recently. There's absolutely no need to feel embarrassed about it. It's more widespread than people realize. When did you first notice the itching or discomfort?
A few days ago, maybe 3 or 4. At first, I thought it was just my scalp being dry, but then the itching got worse and I couldn't stop scratching. My sister helped me check, and that's when we found the lice.
That sounds pretty typical. It usually starts with mild itching, but the constant scratching is a telltale sign. I see here you've tried over-the-counter shampoos. Have they helped at all?
Not really. I mean, I followed all the instructions, but the itching hasn't gone away, and I think I can still feel something crawling. I don't know if it's just in my head, though.
It can definitely feel that way. Lice are resilient creatures. Even after using lice-killing treatments, sometimes they can persist if some eggs or nits are left behind. The nits are usually attached to the hair near the scalp and can be harder to remove, even after treatment.
That's exactly what I'm worried about. I mean, I've washed my hair a few times, but I don't know if I'm getting rid of all of them. Is there anything else I can do?
Yes, there are a few things. First, you'll want to use a fine-tooth lice comb to physically remove both lice and nits after using the shampoo. It's best to do this on wet hair because the water makes the lice less active and easier to catch. Comb carefully through small sections of your hair, starting from the scalp and working down to the ends.
I've heard about that, but it sounds so tedious. How often should I be combing?
It is tedious, but it's necessary to ensure you remove as many lice and eggs as possible. You'll want to comb daily or every other day for at least 2 weeks, even if you don't see any live lice. The idea is to break the life cycle of the lice, which means catching any new lice that might hatch from missed nits.
Okay, so shampoo and combing. Is there anything else I need to do at home? I've heard that lice can live on bedding and clothes.
Good question. While lice cannot survive long off the human scalp, usually no more than 24 to 48 hours, it's still important to clean items that have been in contact with your head. That means washing bedding, hats, and scarves in hot water and drying them on high heat. Vacuuming sofas and car seats is also a good idea. And don't forget about hairbrushes and combs, soak them in hot water for at least 10 minutes.
That's a lot to think about. Should I also be worried about my family getting lice?
Lice spread through close head-to-head contact, so it's possible for others in the household to get them. I recommend that your family members check their hair for any signs of lice or itching. If anyone has them, they'll need to follow the same treatment plan. Avoid sharing items like brushes, hats, or towels for now, just to be safe.
I see. What about my work? I don't want people to know about this, but I also don't want to spread it.
I understand your concern. You can go back to work as soon as you've started treatment. Head lice aren't a reason to stay home, but you should avoid close contact with others until you've successfully gotten rid of the lice. Most people won't even notice if you're careful.
That's good to know. Is there any chance I'll have to deal with this again? I'm really hoping this is a one-time thing.
Lice can come back, but the key is being vigilant with follow-up treatments and household cleaning. It's also helpful to avoid sharing personal items, and if you're around children often, just check your scalp regularly. There's no way to guarantee you'll never get them again, but with the right precautions, you can significantly reduce the risk.
Okay, that makes sense. It's just so frustrating. I didn't even know how easy it was to get lice as an adult.
Many people think lice only affect children, but adults can get them just as easily. It's more about being in close proximity to someone who already has lice, regardless of age. The important thing is that lice are not a sign of poor hygiene or anything like that. They simply move from one person's hair to another through direct contact.
I'm definitely learning a lot. One last question. If the treatments I've used aren't working, what's the next step?
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a medical professional explaining a diagnostic procedure to a colleague. Now read the question.
Dr. Harris, I have a question about the 45-year-old woman's skin biopsy report.
Sure. Have you reviewed the pathology report?
Yes, I have. The report shows atypical melanocytes in the epidermis, with irregular nests extending into the dermis. Doesn't this confirm the diagnosis of melanoma?
Yes, it suggests melanoma, but there's another important factor here. The patient's history of significant sun exposure and noticeable skin changes over the years strengthens this diagnosis. You must consider the clinical context alongside the pathology.
Right, I hadn't fully accounted for the patient's history.
Look at question 26. You hear a surgeon discussing about a patient. Now read the question.
Around the incision site, but it's manageable with the painkillers prescribed. He seems stable.
Good. I've added some notes regarding his recovery. We need to keep an eye out for any signs of infection, especially redness, swelling, or discharge around the incision. His fever should also be monitored closely over the next 24 hours.
Understood. I'll make sure the team is aware to watch out for any symptoms of infection.
Great. Also, ensure his pain is managed effectively but not over-medicated. We want him mobile as soon as possible to prevent any complications with his recovery. If there's any significant increase in pain or fever, call me immediately.
Absolutely. I'll make sure he's monitored closely for both infection and pain control.
Thanks. Let me know if anything changes.
Now look at question 27. You hear a medical professional explaining ICU handover process. Now read the question.
Thank you for being here today. As we have discussed before, the ICU handover process follows a structured format. Patient details, current ventilator settings, sedation protocols, infection control measures, and overall care plan. Each section of the handover should be concise yet comprehensive, for example, when discussing ventilator settings. It's not necessary to cover every technical parameter unless it's clinically relevant to the patient's condition. You should mention key aspects, like the fact that the patient is currently on 40% FiO2 and 8 PEEP. Additionally, if there's been a change in the patient's oxygenation, or if they have failed any weaning trials, this should be included. When you move on to sedation protocols, it's important to note whether the patient is currently on propofol or midazolam, and mention the sedation goals, like keeping the patient calm but not over-sedated. Then, for infection control, ensure to include relevant details like whether the patient is on contact precautions due to MRSA, or if they've had recent blood cultures showing signs of sepsis. Finally, when summarizing, mention if there are any ongoing concerns or changes in the treatment plan, such as discontinuing sedation for a spontaneous breathing trial.
Now look at question 28. You hear a neurologist explaining to a patient about her recent speech changes. Now read the question. Doctor, I'm really worried. Ever since the accident, my speech has changed. Everyone says I sound like I'm speaking with a different accent, but I've never lived anywhere else.
Yes, I understand your concern. This condition is known as foreign accent syndrome. It's very rare and can occur after brain trauma, like the one you had in the accident. The speech centers in the brain are affected, which changes the way you pronounce words.
But I don't feel any different otherwise. Is this something permanent?
It's difficult to say. In some cases, patients recover as their brain heals, while in others, the speech changes can persist. The good news is that we can begin speech therapy to help you regain more control over your pronunciation.
Now look at question 29. You overhear a conversation between two doctors discussing delays in lab results. Now read the question.
It's been such a frustrating day.
I can imagine. You must be exhausted dealing with all these delays. What exactly is the issue?
Well, the lab results are taking far too long to come back. In theory, most of the tests are supposed to take about 30 minutes, but today, they've been taking over 2 hours.
That's crazy. I assume this is backing up everything else in the department.
Exactly. The patients are waiting far too long for diagnoses, and that means we can't make any decisions about discharges or treatments. Everything is grinding to a halt.
And I guess this isn't just affecting the emergency cases, but even the patients already admitted, right?
Yes, it's awful. The patients waiting in the department for test results, as well as those waiting in other parts of the hospital for follow-ups, are all getting delayed.
And with the department full, this must be having a ripple effect on patient care throughout the hospital.
It definitely is.
The lab delays are throwing off everything.
So what's causing the delays?
Now look at question 30. You hear a veterinarian and the owner of a dog discussing the importance of performing a necropsy. Now read the question.
Necropsy can be so helpful in understanding what happened to Rocky. Okay. A necropsy is very similar to an autopsy, but it's performed on animals. It helps us understand the cause of death and can sometimes reveal underlying diseases that may not have been detected while the animal was alive. In Rocky's case, performing a necropsy could help us learn if there was an undiagnosed condition or if there were any complications that led to his unexpected passing.
I see. And what do you do during the necropsy?
During the procedure, we examine the internal organs, tissues, and sometimes take samples for further laboratory tests. This can help identify any infections, cancers, or even confirm if there was something genetic that we didn't pick up on earlier.
Would it also help if there was something contagious?
Absolutely. One of the most important reasons to do a necropsy is to identify any infectious diseases. If we find something like that, it could help protect other animals, especially if Rocky had any contact with them. So, necropsies are often crucial in preventing outbreaks.
That makes sense. I didn't realize how important it could be.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For question 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Extract 1. Questions 31 to 36. You hear an interview with Dr. Alice Thompson giving a detailed presentation on traumatic brain injuries. You now have 90 seconds to read questions.
I'm joined today by Dr. Alice Thompson, a specialist in neurological rehabilitation who works extensively with patients recovering from traumatic brain injuries, or TBI. Now, Dr. Thompson, TBI can have long-term effects that are difficult for patients to cope with. Could you tell us how patients tend to react when they begin to realize the full extent of these effects?
It varies greatly. For some patients, the severity of the injury is clear from the outset, so they're better prepared for what's to come. But others, particularly those with mild to moderate TBIs, might initially believe that their recovery will be quick. When the long-term effects, such as memory problems or mood changes, start to set in, it can be a real shock. One of my patients, we'll call him Mark, said it felt like losing control of his own mind. The frustration of not being able to remember basic things was overwhelming. He likened it to being trapped in his own body, but with someone else at the controls.
That sounds incredibly difficult. Memory issues are one of the most common long-term effects of TBI, aren't they? How do patients typically cope with these challenges?
Yes, memory loss is a very common issue, and it can affect day-to-day functioning. We work with patients to develop strategies to compensate for this. For example, we encourage the use of external memory aids like smartphones, calendars, and notes, which can help patients keep track of important information. Mark, for instance, found that setting reminders on his phone for even simple tasks helped him regain a sense of control. In more severe cases, we introduce cognitive rehabilitation exercises aimed at retraining the brain to improve memory function. It's a slow process, but many patients do see improvements over time.
Mood changes are another difficult symptom to manage after TBI. Could you explain why this happens and how you address it in your rehabilitation program?
Absolutely. Mood swings, irritability, and even depression are common after a TBI because the brain's emotional regulation centers are often affected. Patients can experience sudden emotional outbursts or feel depressed without understanding why. This was the case with another one of my patients, Sarah. She would go from being completely fine to intensely angry over small frustrations, and it was really hard for her to cope. We addressed this through a combination of therapy and medication. Cognitive behavioral therapy, CBT, is particularly effective because it helps patients recognize triggers and develop coping mechanisms. Medications like antidepressants may also be used when necessary to help stabilize mood.
And what about the physical aspects of rehabilitation? I imagine this is another key area where patients struggle.
Yes, physical rehabilitation is crucial, especially for patients with moderate to severe TBI. Depending on the injury, patients may experience balance problems, difficulty with coordination, or even paralysis. Physical therapy focuses on retraining the body, improving mobility, and rebuilding strength. We work closely with patients to set small, achievable goals, which helps them see progress and stay motivated. For example, Sarah initially had trouble with balance, so we started her on simple exercises like standing on one leg or walking on uneven surfaces. Over time, these exercises became more complex, and she's now regained much of her mobility.
That's amazing to hear. I've read that fatigue is another common issue for TBI patients. How do you help them manage that?
Fatigue is one of the most challenging symptoms because it's not just physical tiredness, it's also mental fatigue. Patients often find that even simple tasks like reading or holding a conversation can exhaust them. We work on energy management strategies, teaching patients how to pace themselves and prioritize activities that are most important to them. Rest periods are crucial, and we emphasize the importance of balancing activity with plenty of recovery time. We also look at lifestyle factors, such as sleep hygiene and diet, which can contribute to managing fatigue.
It sounds like managing the effects of TBI is a long and difficult journey for many patients. Is there any recent advancement in treatment that offers hope?
Yes, there's been significant progress in neuroplasticity research, which is the brain's ability to rewire itself. This has opened new doors in rehabilitation. We now incorporate techniques like transcranial magnetic stimulation (TMS) and virtual reality exercises to help stimulate brain function and encourage recovery. While these are still relatively new treatments, we've seen promising results. For instance, patients who've used virtual reality for balance training often report feeling more confident in their movements and experience. Fewer falls. The key is that the brain continues to adapt, even years after the injury, so recovery is possible, even in the long term.
That's encouraging to hear. And your research is ongoing, I assume?
Absolutely. We're always looking for new ways to improve patient outcomes. We continue to track how these new techniques work over time and are always refining our approaches based on what we learn. The most important thing is that patients remain hopeful and committed to their rehabilitation. With the right support and strategies, they can regain a lot of what they've lost.
Thank you, Dr. Thompson. It's been fascinating to learn about how TBI patients can overcome these challenges with the right care.
Extract 2. Questions 37 to 42. You hear Dr. Jordan Matthews giving a detailed presentation on dietary changes with diabetic patients. Now, read the questions. You now have 90 seconds to read questions.
Good afternoon, everyone. My name is Dr. Jordan Matthews, and I'm a clinical nutritionist here at the hospital. Today, I'll be addressing a topic that many healthcare providers find challenging, discussing dietary changes with diabetic patients. Dietary habits are deeply personal and can be influenced by culture, emotional needs, and lifelong preferences. As we all know, diabetes management often hinges on diet, but this can make the conversation particularly delicate. Many patients come into consultations already aware of the need to change their eating habits. However, like many aspects of health, knowing and doing are two entirely different things. Patients may feel overwhelmed, defeated, or even resistant to altering their diet, especially if it feels like a restriction rather than a positive lifestyle change. This is where our role as healthcare providers becomes crucial. We need to foster a conversation that feels empowering rather than limiting, one that allows the patient to take ownership of their health without feeling judged or deprived. One approach I've found particularly effective is starting the conversation by gauging where the patient stands. For example, asking, "How do you feel about your current eating habits in relation to your diabetes?" allows the patient to reflect and provides us with insight into their mindset. This question also avoids making assumptions, which is important in building trust. It's vital to remember that a patient's relationship with food is often tied to emotions and culture. For instance, when working with patients from different backgrounds, their traditional diets may not align with conventional diabetic meal plans. Instead of focusing solely on the clinical aspects of nutrition, we must be culturally sensitive and work within the framework of their preferences. This could mean modifying existing meals rather than completely eliminating them. During consultations, I try to avoid using terms like bad foods or restricted diets, as these can be demotivating and even trigger guilt or defensiveness in patients. Instead, I focus on terms like nutrient-dense or balanced meals to frame the conversation positively. It's essential to emphasize that the goal isn't to take away foods they love, but to find healthier ways to enjoy them. Another strategy I use is shifting the focus from restriction to addition. For example, instead of telling patients what they can't have, I suggest introducing more vegetables, whole grains, or lean proteins into their meals. This keeps the conversation positive and action-oriented, focusing on what can be added rather than taken away. Offering realistic alternatives like swapping white rice for quinoa or adding leafy greens to a favorite dish can make the dietary changes feel less daunting. Open-ended questions also play a critical role in guiding the conversation. Asking questions like, "What challenges have you faced when trying to make dietary changes?" gives the patient the opportunity to express their frustrations or concerns. This not only helps identify potential barriers, but also shows that you're genuinely interested in their experiences and are there to support them. When it comes to diabetes management, I often tie dietary changes to tangible health outcomes. For example, explaining how reducing sugar intake can help stabilize blood glucose levels and prevent long-term complications like neuropathy or cardiovascular issues, can motivate patients to take action. By framing the conversation around improving quality of life rather than focusing solely on weight or restrictions, patients are more likely to feel empowered to make sustainable changes. Of course, not all consultations go smoothly. There are times when patients resist making any dietary changes despite knowing the risks. In such cases, I try to focus on incremental changes. Even small adjustments, like reducing portion sizes or cutting back on sugary drinks, can make a significant impact over time. It's important to celebrate these small victories with the patient, as they can serve as building blocks for larger, long-term changes. Providing ongoing support is another critical component of successful dietary management. This could include giving patients educational materials like meal planning guides or connecting them with a dietitian for follow-up support. I also encourage patients to involve their families in their dietary journey, as family support is often key to success, especially when shared meals are a part of daily life. In conclusion, the conversation about dietary changes with diabetic patients doesn't have to be one of restriction or limitation. By focusing on open-ended questions, cultural sensitivity, and incremental changes, we can help our patients make empowered choices about their diet that are sustainable and aligned with their overall health goals. Remember, our role isn't just to provide information, it's to motivate, support, and guide our patients in a way that fosters long-term success.
That is the end of Part C. You now have 2 minutes to check your answers.